Hi there, it's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
So thanks, Sarah. Thanks very much, and good evening, everyone. Thanks so much for joining. I see there's quite a few people on the call tonight, which is great. And obviously, there's a lot of interest and questions, hopefully, and inquiries about methotrexate. It's quite a common medication that we use as rheumatologists in our clinical practice with our patients. And so I think hopefully tonight will be a little bit of a mind-blowing session, hopefully. I'm trying not to oversell this, but to kind of sort of, demystify methotrexate and kind of get a bit more of a handle on really the practicalities of it, and hopefully reassure people that it's a relatively safe drug and so forth. And, there's things that we need to be aware of, but there's a lot that you can read on the internet, but the internet is not always 100% accurate, as we know. So maybe what I'll start off with is I'll just kind of go through what we'll cover sort of this evening, and go from there. So essentially, I thought it would be good to kind of talk about what methotrexate is and the why, the when, and how we use methotrexate in rheumatology. I think covering the side effects or the potential side effects associated with the medication. Apologies, there's the first spark for the evening. The common ones and the less common ones are going to be important to sort of know about. And monitoring. So a lot of people get really concerned about methotrexate and the fear that it's going to cause long-term side effects or long-term problems, and how things are going to be monitored. So I'll cover that. And then there's some special circumstances around which we discuss methotrexate in a bit more detail with patients, and kind of consider when it's appropriate, when it's not appropriate to use, or stop and restart, and so forth. And then we'll just kind of summarize the things up at the end. So I'll throw it off to Sarah. I'd like to firstly ask everyone a poll question. This is number one. Now, there's no right or wrong answer. The first question is, how would you describe methotrexate? How would you best describe it? Is it A, an immunosuppressive drug? Is it an immunomodulatory drug? Or is it anti-inflammatory drug? I'll give you guys a few seconds to sort of... Geez, everyone's just pressing buttons and answering questions.
That's good.
Fantastic.
This is a good question, Pauline. I think, yeah, it'll be good for you to explain the difference of terms and how you classify it and why it makes a difference to know which one it is. Okay, I think that's most people. 90 people have voted. So how about we end? Why don't you tell everyone the answer, Pauline, and then I'll end it.
No. So I can see there the majority of people have put down that it's an immunosuppressive drug, and that's fantastic because that's the first myth that I'd like to bust. It's essentially an immunomodulatory, sorry. That's all good. Oopsie daisies. So it's essentially an immunomodulatory drug. So a lot of people think, and we've gathered that a lot of people think of methotrexate as being an immunosuppressive medication because they often associate it with the use in chemotherapy. So yes, methotrexate is used for cancer therapy, but the very big distinguishing feature there is that we use it in rheumatology practice as an immunomodulatory medication in such a much smaller dose and lower frequency compared to how oncologists and other physicians use it in the context of chemotherapy. And so, a lot of people worry that, if they get sick or, if they've got grandchildren or children, or if they go and visit somebody who's a bit sick, that they need to be really quite cautious with getting infections or passing that on because their immune system is very suppressed. That's not actually the case. And I've had a few patients actually who have told me that when they were in hospital for different reasons, they were really isolated, and they essentially felt like they had to be bubble wrapped, and they were purple gowns and boxes around their rooms, and it had to be isolated because they were being treated like a chemo patient. So one of the biggest messages that I want to send you guys is that it's not an immunosuppressant medication. It does modulate your immune system, which means that it kind of affects it in a way to help reduce inflammation. And it does that by blocking this enzyme called dihydrofolate reductase, and to spare you the whole pathophysiology of it, but essentially that's how it kind of reduces inflammation. And inflammation is how you experience, or patients experience, pain and stiffness and swelling sometimes. And that's essentially how it does it. And the aim of having less or no inflammation, and therefore less or no pain, stiffness, or swelling of the joints, the better people can feel in terms of their joint function, and overall just functioning on a day-to-day basis. It's really important to understand as well that the reason why we use this medication in reducing inflammation is because it has other effects on top of just the joint aspect. So by reducing inflammation, it reduces your risk of cardiovascular health problems, so heart attacks, strokes. It also reduces your risk of osteoporosis, so your bones weakening. So it has a lot more downstream effects that are positive by reducing inflammation, and that's why we use methotrexate and drugs similar to that. All right. So now onto the why, when, and how we use it. So essentially, we use it because, as I said, we want to reduce inflammation, and we want to do that with the intention of causing downstream positive secondary effects. And when we use it is essentially in situations where we have identified peripheral joint inflammation. What I mean by peripheral joint is I mean things like wrists, ankles, joints in the fingers, shoulders, things like that. So generally rheumatoid arthritis, for example, is not a condition that affects the lower back. It can affect the cervical spine or the neck, but it doesn't affect lower back. So people wouldn't have lower back pain. We don't use methotrexate when people have lower back pain just because, if that makes sense. There are some conditions like psoriatic arthritis, where you can get a variety of different types of joints and areas that can be inflamed, and we use methotrexate in that condition as well. So RA is rheumatoid arthritis, PSA is my shorthand for psoriatic arthritis, SLE is lupus, systemic lupus erythematosus, which is another autoimmune problem where you can get inflammation in the joints and other areas as well. And we find that usually hydroxychloroquine, or HCQ, is the main medication we use, but methotrexate is often an additional drug that we use to help with inflammation in the joints in patients with lupus. There are a number of other conditions like scleroderma and polymyalgia rheumatica, which is PMR, where we can sometimes use methotrexate instead of other medications, and it's found to be quite helpful when it comes to their joint inflammation. Some conditions where there's inflammation as well, but not specifically in the joints, can be an indication for methotrexate, and that includes scleroderma, and particularly in patients with scleroderma where the skin or the lung is involved. There is a lot of evidence that methotrexate helps with those areas, or organs that are involved. Now, the how we use it, I think, is really important in terms of hopefully alleviating a lot of the concern and the, I guess, anxiety related to the use of methotrexate, especially when people think about it as more of an immunosuppressive medication instead of what it is as an immunomodulatory. And we use it, as I said, as a once-a-week drug. So it usually it comes as a tablet. So that's per oral, PO, or we can also use it subcutaneously, which is SC. And that depends really essentially on a patient's preference. Some patients don't like needles, they can't stand the thought of them, whereas some patients are fine with injections, so they don't necessarily mind and they don't want to take a tablet. Sometimes we have to factor in how well someone will tolerate a tablet, for example, compared to an injection, and if there's any particular contraindication. So if there's any particular reasons why someone shouldn't take a tablet or shouldn't be on the injection. The once-a-week methotrexate is associated with once a week folic acid that people have to take. Usually it's the day after. So, for example, I'm not sure how many people on the call are methotrexate. If you give me 2 seconds, I will shoot my dog. So sorry, team. So sorry about that. Of course, it was going to happen, but so the folic acid is really important. But the way that we use it is we have methotrexate, which is a 10 milligram tablet, and the dose can go up to 20 milligrams per week. But the folic acid that is generally taken the day after methotrexate, so just again once a week, but the day after, is really important because the way that folic acid works, even though it's just a supplement, is that it helps reduce the way that methotrexate gets broken down in the liver, and it produces what are called metabolites, so like the byproducts of methotrexate. And it's those byproducts or metabolites that are the things that it can contribute to side effects. So by blocking those metabolites, folic acid helps to, in most part, reduce the risk of side effects. Now, some people will have certain types of side effects that I'll cover in a second that might with the tablet, and that might mean that we need to switch to the injection. And I'll go through that a little bit of that shortly. But I think the really other important thing with methotrexate is that it's important to understand that methotrexate is not a very quick acting drug. So a lot of people will come and say, look, I've got a lot of pain. I just want to get rid of it. If I take this medication, how long is it going to take for my pain to go away? And the answer is going to be dependent on the poll outcome. We've got another question, and if you want to pull up the poll, Sarah.
You had me. I was really following your story there, and I'm
We're
like,
trying to hear through the dog barking.
yes,
I'm
that's
terribly
right.
sorry.
Okay. Oh, let's go back. Sorry. Okay, question 2. We are ready. Okay, have a go, everyone. Hopefully you can see that
So
now.
sorry. How long does it take for methotrexate to take full effect? Immediately? I already gave you a bit of that answer. It could take a few weeks. It can take a few months. Let's see what we think.
Good crowd tonight. Everyone's got some ideas and thoughts, which is good. We've got over 100 people now have popped in an answer.
That's great.
I'll give you seconds. Yeah. Okay. Give it away, Pauline. What's the answer?
So it's not immediately, unfortunately. I'm sorry to report. And it's not, so the correct answer is can take up to 3 months. So generally we say we need to give the medication about 3 months, roughly, to see if it has taken full effect and if it's actually effective on its own as the only drug that somebody needs for the condition that they're being treated for. Sometimes, though, the onset of effect can be quite relatively quicker, and that can be a few weeks. But generally, if somebody came to me and said, look, I don't feel better, it's been 6 weeks, I don't think this medication is working, then the first thing that I would probably say is, it takes longer. We're only about halfway there, and we need to give it a bit more time, as long as you're tolerating it okay. So if you have side effects, or if you're not tolerating it, or there's issues with taking it, let me know, because then it might be that we don't actually keep pushing on to get to the 3-month mark, but we actually have to stop it straight away or change something about it. But if they came to me in 3 months and a patient said, I don't feel any better whatsoever, then that would make me think maybe this drug is not the right one for them. And unfortunately, I know that sounds like 3 months has been wasted, but the reality is the drug doesn't work quick enough for us to be able to make that call of effectiveness any sooner than a few months. Now, if somebody comes back after 3 months and says, I don't feel it's made a single difference in terms of how I'm feeling, I still have the same level of pain, the same level of stiffness, my joints are still swollen, then I wouldn't really give it much longer. However, if somebody, I should say, I wouldn't give it much longer and keep pushing on, I would think about switching the medication if they had zero effect from it. If they had some effect from it and they said maybe 50% better, there's still some improvement, but it's just taking a bit longer, And I would say maybe that person is probably in the minority of people where it might take even a little bit longer than that, and even up to 6 months. But in general, it can take about 3-ish months. Um, I can see that there's some questions in the thing. Did you want me to stop, Sarah, and just take some questions at the moment, or shall I continue?
How about I think folic acid has come up in a few different
Okay.
questions. So I guess I'll try and summarize a few people's comments. So people have said some of them are taking it the day before and the day after. Some people taking it multiple times per week. So how much variation would you say is normal, and why might be some of the reasons that different people need different, dosages of folic acid?
Yeah, amazing. Very good question. So generally, we know that in large part, the evidence says that once a week, folic acid, 5 milligrams, should be sufficient to help reduce any possible side effects. However, I know some of my colleagues who have been practicing for decades, for example, may have put patients on folic acid every day of the week except the day of methotrexate. Now that's really so, and that might be fine. There might be a reason for that. Sometimes people feel a bit fatigued, or they might have some mouth ulcers, or they might have some other side effects where we know sometimes if you increase the dose of the folic acid, which is to say you take it more than once a week, that can help with those side effects, but sometimes that doesn't help. So if somebody had some intolerances, depending on what they were, I would certainly consider increasing the dose of folic acid to more than once a week. But the really important thing is, even if you increase the dose to say 4, 5, 6 days a week, the important thing really is that you should not take folic acid on the same day as methotrexate, because people feel sick with that. The way, as I mentioned before, the way that methotrexate is broken down, and you get those byproducts, that happens within, I guess, the first 24 hours or so. So when you take folic acid at the same time, it doesn't, there's something about it, and I don't think anybody can necessarily explain how this happens, but it just makes people feel sick. A lot of people have gotten away with accidentally taking it on the same day as methotrexate, but I certainly wouldn't recommend that as the routine thing to do. So if I, for my patients, for example, I start people on methotrexate once a week, whether it be 10 milligrams or 20 milligrams, and then I say just take it the day after. If there's any issues, come back to see me, let me know, and then we can work out whether it's appropriate based on what you tell me to take it more frequently, or we have to actually do something about the methotrexate itself, and the folic acid changing it won't make a difference to how you're feeling if it's in a negative way.
Great. I might just ask you one other question,
Yeah.
if that's cool. So I know you've said, yeah, you've got tablets and then there's injections. In your experience, because someone's shared they tolerated, the subcutaneous form much better than oral. Have there been any patterns? Like, and now that you've been practicing for years, is it, have you got any particular, feel as to what's might work better in someone versus another person, or you really just have to pick one, start, give it a try, and then the client will come back and tell you?
Yeah, look, that's a brilliant question as well. So it's really difficult to kind of predict who will not respond or who might not tolerate oral methotrexate and who should go straight onto injections. For the most part, I want to say, don't quote me on this number, but I would say like 90% of the time, patients are started on oral, right? Now, if somebody says, I cannot, I have swallowing problems. So for example, with scleroderma, you can get swallowing issues, or some people just don't tolerate a lot of different types of tablets, and they're very conscious of that. Then I might say, okay, well, the option is subcutaneous essentially, and then we can go from there. But most of the time, because people tolerate oral, we start people on oral. And then it's only if they have certain issues like nausea, particularly nausea, vomiting, or diarrhea, so gastrointestinal symptoms, would I then change someone's oral and put them on subcutaneous injections, and then generally those gastrointestinal side effects go away and they're much better tolerated. But it's very difficult to sort of personalize or predict who should go on what type of preparation, essentially. We just know that they're both pretty effective. I will say, though, that the difference between the two is that with subcutaneous injections, you don't kind of get the same sort of breakdown of the methotrexate by the liver, which means that more of that methotrexate itself goes to the joints, to the areas that need it. That's not to say that you're more likely to then have toxicity or side effects related to it because it doesn't get broken down. But it just means that, for instance, if I've got somebody on 20 milligrams of oral methotrexate, I think I'm probably getting up to 20 milligrams. Whereas if I had somebody on methotrexate 20 milligrams subcutaneously, they're probably getting a little bit more than 20 milligrams, which is fine, which is still safe. I mean, the maximum dose would probably be around 25 milligrams per week. I generally don't go over 20. If somebody needs more than 20, then they need another drug.
Okay. I think keep going. There's more questions, but I think for now, keep going and we'll.
Okay, no worries.
Right.
So hopefully that kind of puts things into perspective in terms of the onset of action and when to actually expect some improvement with methotrexate. So then I really want to cover a bit more the side effects, because a lot of people worry about this, and I know Google has a plethora of possible side effects that can be associated with methotrexate. Again, I think some of it might be more in the context of cancer therapy. So a lot of people will have heard of patients that get really nauseous, really have really bad vomiting, are quite unwell when they're on methotrexate when they have it as chemo. Again, this is very different circumstance and different context with the doses that we use. And so I would say in the most part, the majority of the time, people tolerate it really well, tablet or injection. However, some of the common side, when I say common, I mean if somebody develops a side effect, it might be one of these things: possible nausea, vomiting or diarrhea, so that's NVD, hair thinning or hair loss, mouth ulcers, so you get sort of sores on the inside of your mouth, on the cheeks, fatigue, usually for the first 24 hours of taking it. And even if people have fatigue, it's not the overwhelming fatigue where they're absolutely bedbound and they just can't function. It's more like, I just feel really tired, like I just can't be bothered to do anything. I'd rather just sit on the couch or be in bed, kind of thing. But or I can still do stuff, but it's just very minimal. A very small proportion of people might feel so fatigued that that it starts to affect their quality of life, in the sense that they're not they're a bit more reluctant to go for brunch on the weekend or something if they take methotrexate on the Friday because they feel quite tired or whatnot. So it's starting to become a bit more pervasive, and it affects their quality of life. And that's something that we need to be aware of so we can manage that. And then the more, I would say, uncommon side effects and things that people sort of worry about a lot more, though, include things like bone marrow suppression and deranged liver function tests. And you know, even as I say that, I can appreciate that that would be very concerning. But again, we monitor people's blood tests quite regularly and to check for their bone marrow function, their liver function tests, their kidney function, as well as their markers of inflammation, which is important. So like with any medication, you can get a rash. Some people have reported headaches. And then, as I mentioned, the overwhelming fatigue that affects the quality of life for the QOL. But again, that's very much not so much a very common side effect. I always give my patients a copy of the information sheet from Arthritis Australia, which is a fantastic resource to access, and a lot of people can just access that online if you go onto Google and search the Australian Rheumatology Association website. There's a section for patients and different resources for conditions and medications, but I always give patients information sheets from that particular resource on the side effects, and part of that will include a lot longer list of possible side effects, including, you know, skin cancer and you know, infections and so forth. And certainly that's true, you can get those things, but again, the risk of those things happening is very, very low. So the overall benefit far outweighs the potential risk of side effects from that. I will get to infections and cancer in a little bit, but those are generally the main side effects that that we kind of consider and talk to patients about. Now, I mentioned that the use of methotrexate is safe. We monitor patients both clinically in terms of how their symptoms are going, whether they're getting any side effects, excuse me, as well as whether, side effects physically, I mean, like gastrointestinal stuff or hair loss, etc. But we also monitor for side effects that we can see in test results, essentially. And so the main types of screening tests or tests that we use for monitoring involve predominantly blood tests. So things like checking their full blood count, which is the FBC, the UEC, which is the kidney function, LFTs, which are the liver function tests, CRP and ESR, which are the 2 markers of inflammation. I generally check those every month when somebody starts methotrexate. And then once things are stable and they're tolerating it well and everything is pretty hunky-dory, essentially, then I might space that out to every 3 months or up to every 6 months for patients that have been pretty stable and their disease is under control and they're tolerating the medication well, and historically their blood tests that have been more frequent have been normal. Some patients, particularly those with rheumatoid arthritis or RA, especially if they're seropositive, which means that their antibodies for rheumatoid arthritis are positive, I would also be doing a baseline chest X-ray, so that's the CXR. Because we know that patients with rheumatoid arthritis, and particularly those with positive antibodies, are at slightly higher risk of having complications related to their rheumatoid arthritis that involve the lung, which includes nodules. And so I want to get that checked out as a baseline to make sure that at the beginning of diagnosis or from as early as symptom onset as possible, that there are no complications from a lung perspective. Now, one of the big myths as well is that methotrexate can cause lung damage. Now, big myth. There is a lot of evidence to suggest that the risk of methotrexate-related lung disease or lung damage is extremely low. So people might have, I don't know if any of my patients are on this call, but patients will have seen that when I give them a request form for a chest X-ray, that they have, patient has rheumatoid arthritis on methotrexate, baseline check for interstitial lung disease, nodules, other issues, essentially. I want to make it clear that I'm not doing the chest X-ray because methotrexate can cause problems. It's more that they've got a baseline condition that increases their risk of lung problems in the form of rheumatoid arthritis. So if somebody is on methotrexate and they've got lupus, or they've got psoriatic arthritis, or they've got another condition that isn't associated with a higher risk of lung problems, I wouldn't be doing a baseline chest X-ray. So those are essentially the 2 tests that I check, and the chest X-ray being in a specific disease condition.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. But otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.